So this is the cisplatin eligible patients. So they are different sequencing. Now coming to how we are going to sequence them. So clinically and theoretically, two different things are there. So what is the theoretical best approach? As already discussed by Dr. Ravi, that you start with a switch maintenance, give chemotherapy, switch to the immunotherapy after that, and post immunotherapy, then the patient progresses, then you initiate the second line. But in our setting, hardly 1 to 2% of the patient goes for this switch maintenance. Maximum patient goes what is called the wait and watch maintenance. That you give the first line chemotherapy for 4 to 6 cycles, stop the therapy, monitor the patient, and once the patient progresses again in 6 months to a year, in that case you initiate the second line therapy in our patients. The continuation maintenance is the other therapy in which pembrolizumab, the immunotherapy has been combined with chemotherapy. So it is also found not to be more beneficial than as a switch maintenance, and it is also not so practical to be used. So the wait and watch approach, what we see that even if you start with the chemotherapy, only 50 to 80% of the patients achieve disease control. However, OS is limited in this case also by the chemotherapy resistance, but median OS going from 14 to 15 months in this group of patients. So IO plus chemotherapy, the other thing which I have already told that this is a mechanism, but of all the trials, whether they have taken atizo, pembro or durvalumab, all these are negative trials till date, though the atizo data is still pending, without any significant difference in the overall survival and second analysis. So they haven't met their OS endpoint. So this approach has been not used nowadays. Most commonly we are not using. So how to maximize the outcome? So that is the switch maintenance therapy, which has already been discussed. So I'm not going so detailed in this therapy. That you are starting with the first line chemo, then switching to the immunotherapy, adalimumab, and then after disease progression, you are going for the second line this group of patients. So it improves the outcome, and that's the best outcome you are going to get is only with this. That is something around most patients progresses within 9 months of initial chemotherapy, and that part is best taken care of by adalimumab in this setting. So even the long-term data, if you see, if overall population we say there is something around the median OS is around 24 months with adalimumab. Maintenance you are giving as compared to 15 months if you are giving only chemotherapy in this population. And at 3 years, you are seeing something 1/3 of the patients surviving. So that's a big number for a metastatic bladder cancer patient in this group. And if you take a PD-L1 positive population, if you separate them, so this outcome improves further. The median OS goes to something around 30 months, that is 2.5 years in this group of patients, and the 3-year OS is around 50% of the patient is going to survive if they are PD-L1 positive with this approach. So even in the metastatic bladder cancer, we can get a longer survival if we are judiciously using all these medicines. So with adalimumab, what we see is the highest survival up to 30 months in this group of patients as compared to all other approaches you are using. Even if you are using only checkpoint inhibitors upfront, which gives a survival only around 15 months. So the treatment for cisplatin eligibility and platinum eligibility, so I have discussed that both are different things. If you are cisplatin eligible, still you are eligible for carboplatin, but if you are platinum ineligible, in that case you are not. So it is just like this case, if you have a creatinine clearance of 35 ml but the creat of 1.9, so what are you going to plan for this patient? Whether a gem carbo, pembro or atizo. So it all depends, since this patient is surely a type 2 diabetic, it's a cisplatin eligible patient, if you may go for a gem carbo. So why does the role of other comes? If we see, if there is a cisplatin eligibility, give gem carbo. The OS is 9.3 months, and carby regime gives a OS of 8.1 months. So the OS is still very less with the patient if you are giving with a carbo-based therapy as compared to the cisplatin, because cisplatin surely have an upper edge on treating these group of patients. So outcomes in these patients are very poor, and 20 to 40% are never treated even in this group of patients. So that's the most important thing. So there comes the role of immunotherapy as already discussed. And if you are using in the first line immunotherapy, the median OS is going around 16 months with atizo to 12 months with pembrolizumab in this group of patients. So, but atizo and pembro are alternative for patients with only one PD-L1 positive who are not eligible for cisplatin-based chemotherapy. That one has to remember. So the level of evidence is very much weaker. So if a patient is fit for chemo followed by maintenance adalimumab, you should go for that approach only. If he is not at all fit, then only you have to think of immunotherapy in this group of patients. The pros and cons of to 80% of the patients with chemotherapy get response, but with this immunotherapy, this comes down to 20 to 40% of the patients who are getting the response. But responses are durable. That is the most beauty of this immunotherapy. Quality of life surely improves because the toxicity profile is clearly different, and biomarkers somehow helps slightly in this group of patients to help our treatment in this group of patients. So for cisplatin ineligible patients, so you have got the options of Gemcarbo, Mcadi, or Pembro or Atinzo, depending on the CPS score in this group, which has already been discussed. So now comes the second generation drugs, which are the antibody drug conjugates in bladder cancer. So there are two drugs which is in picture, and basically it is in use also. If the patient is affordable, we can get it also. We have got access to this infortumab vedotin or sacituzumab govitecan in this group of patients. So these are basically humanized antibody targeting this infortumab is targeting Nectin-4, a transmembrane cell adhesion molecule, and whereas the sacituzumab is basically the SN38 payload that is a modulator of irinotecan chemotherapy. This targets TROP2 and epithelial cell surface antigen, and so both are being FDA for treatment in this group of patients. So if even in the first line, there is a data now coming for infortumab vedotin in combination with pembrolizumab in this cisplatin eligible patient. So these group of patients, what we see, there 93% of the patient has got a tumor reduction if you are using infortumab with pembrolizumab. There is a CR rate of around 15% and a partial response is seen in around 58% of these group of patients. And the PFS is, where the best PFS is 12.3 months and the OS is still not reached at 12 months in this group of patients. So might be this combination in near future we may be getting if the study is available in our setting. So, but still in first line, Pembro will, I will say that it is not eligible only for patients who are not eligible for any platinum containing regime. Otherwise, go for Gemcarbo in this group of patients if they are cisplatin eligible. So now coming to this second line post. So we have either treat the patient with chemotherapy, which is our major bulk, 90% of the patients who are only treated with chemotherapy. A few patients go through chemotherapy followed by IO, that is Adalimumab. There are now patients also, the poor elderly patients, we are eligible, we are giving only IO in the first line. So we have planned the second line therapy also in these group of patients. So if we have given only chemotherapy in the first line, then the most important drug is the pembrolizumab, which comes in second line. And this is a keynote 45 study which has compared Pembro with the single agent either paclitaxel, docetaxel, or mixed. And this has clearly shown that the median OS with pembrolizumab even in the second line is 10 months as compared to chemotherapy, which is 7.2 months. So this is definitely having a greater edge of treatment of pembrolizumab over the single agent chemotherapy in this group of patients, and the side effect profile, as we already know, is much better and is tolerable as compared to others. So what we have seen in the second line therapy, if you are giving immunotherapy, the chemotherapy shows a response rate of only 10%. Whereas the immunotherapy, whether you are using Pembro 20%, Evo 20%, Durva, so all immunotherapy are showing a response rate slightly higher in the second line as compared to chemotherapy if you are using after post chemotherapy, though no head-to-head comparison is available for these patients. So how we are going to sequencing, and so this is the best sequence for anything. In first line you get Gemcis, then Adilo, and then the second line either you are doing a single agent chemotherapy in this group of patients. So the Javelin trial, which has already been discussed, so what is the second line most patients receive? If we see that the most patients have been re-challenged with a platinum based therapy also, if they are used for a longer period of time, they are again re-challenged. Few patients have received in a second different immunotherapy, and most of the patients have got the single agent chemotherapy, whether it's a demystify, paclitaxel, or the second generation drugs, third generation like infortumab vedotin, adalimumab, medicated. These are the things which have been given in this group of patients. And the overall survival, even in this trial, if say the patient hasn't received any therapy, the overall survival was 18 months. But if it is re-challenged the second line, there is a definite benefit of around 4 to 5 months in the survival of this group of patients. So it's coming to 22 months in this. So these are the novel agents which we have tested. So how does it benefit? Adalimumab for the FGFR selected population, the response rate is around 40% with a OS of 13.8 months. Whereas for infortumab vedotin, the overall response rate is 43% with an OS of 12.3 months, and sacituzumab similarly has the greater response OS is 16 months in this group of patients. So the long-term data of infortumab vedotin in the second line of 2 years data has also come, which shows the median OS is around 13 months with infortumab as compared to chemotherapy, which is 8 months in this group of patients. And the number of patients going response is around 7% as compared to 3.4% with chemotherapy with infotuzumab. For FGFR mutation, so now if the patient has received chemotherapy in the first line and do an NGS or a PCR based test and you get a FGFR mutation, what do you going to prefer? Either a immunotherapy or adapitinib in this group of patients. So phase 2 data has clearly shows that the median OS with adapitinib in this population is around 11.3 months. And post chemotherapy even it is 10.6. Prior immunotherapy the patient has received, this survival is around 11 months in this group of patients. So there is a trial which is the third trial which is coming in picture which has taken in consideration adapitinib which has been compared with pembrolizumab. So similar trial, the result is awaited. So we are still in the early phase to comment. So what to use, adapitinib or pembro, but surely a target is present. Better to go for adapitinib in this patient. There is another trial which in the second line has clearly taken in consideration combining immunotherapy with this target FGFR. That is adapitinib with cetrizimab. So the in 22 patients which they have treated, there is an overall response rate of 55% in evaluable patients and 100% disease control. So there is a very good response with this drug which is coming in picture in combination with immunotherapy. And so this is the earlier phase 1-2 study is there. So we are just awaiting the phase 3 studies for this study. Now coming to the other drug, that is sacituzumab. So this sacituzumab in combination with immunotherapy is also the trial has come with pembrolizumab, and this is also shown a good response of 63% shrinkage of tumor, with few patients having around 34% patients having a response of CR or PR in this group of patients. So regarding the NCC and what they say that post platinum or other chemotherapy can go with an immunotherapy, pembrolizumab or nivolumab. But other you may also go for a chemotherapy, single agent battery or gemcitabine in this group of patients. But if it's a post checkpoint inhibitor, in that case it's the best to go for a targeted ADC, either antibody conjugate or a single chemotherapy. Like you may go for a gemcarbo and adapitinib or adapitinib in this group of patients again. So that's the which has already been discussed. Like this cisplatin eligible, start with a cisplatin based chemotherapy, go with amloplan maintenance. If ineligible, carbo-based, that is gemcarbo followed by amloplan maintenance. If ineligible, then IO monotherapy is the norm. And so this is the final chart which we say that how we manage this metastatic disease, PS 2 less than 2, poor renal function, clinical trial, or best supportive care. So you don't have to say a patient, hesitate to say a patient best supportive care if the patient is having a poor performance status and is not fit for therapy. So that is also one of the most important statements that one have to go for best supportive care in this patient. For cisplatin eligible, as you start with the gemcitabine or docetaxel with the maintenance enzalutamide, but thereafter in the second line you can go for a single agent chemotherapy or immunotherapy, or with the based on your molecular profile, like the adapitinib or enfortumab vedotin. Whereas those for ineligible patients, start with an immunotherapy of certain this group of patients. With this, I'd like to thank you and ready to take any questions.
Great, थैंक यू सो मच डॉक्टर अमित. हम लोग आपका प्रेजेंस यहाँ मिस कर रहे हैं, बट विल कीप योर गिफ्ट एंड when you are coming next Thursday, we will hand it over to you. So thank you so much, all our three oncologists, you, Dr. Ravi and Dr. Avinash Pandey, for discussing chemotherapy in detail. You have covered almost all aspect of chemotherapy, immunotherapy, everything. One information I want to share with all present here in the hall, that the NGS next, for your information, SKMC is the only government medical college, probably only medical college in India which is providing NGS services currently free of cost and actually giving report to the patient. There are NGS lab in AIMS Delhi, but they are research lab or research पे चलता रहता है. We are doing research, but apart from doing research, we are also handing over. So far, we have handed over 43 NGS report. Dr. Avinash know, and we are giving report for breast cancer, lung cancer, bladder, oral cancer. ये सारा हो रहा है, and ये free वाला स्कीम जो है अभी और चलेगा. Probably next 6 month to 1 year जब तक हमारी और टीम जो है train, and we are very thankful to State Health Society Government of Bihar for giving us 1.5 crore grant to set up the lab. Was basically set up by Doctors for You with 5 crore contribution, and the running now is supported by Government of Bihar. And my aim and my team aim of NGS is to reduce the cost less than 10,000. Abhi currently the cost of getting NGS is something around 40-50,000 to sometimes 4.5 lakh for sequencing. So this is for your information. So thank you so much to everyone. And now we are heading to the last talk, and thanks by Mr. Vivek Sharma. Vivek Sharma from Uhapo. He will talk about the what the work his organization is doing and the cancer patient support, because cancer patient को केवल medicine ही नहीं, medicine के अलावा that there are like if you ask me, I would say 20% problem is medical, 80% social रहता है. So how they are helping, and I request you to finish in briefly because everybody is waiting for